Welcome to Derm-It Trotter. Don't swear about skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter Don't Swear About Skincare podcast. Today we've got an exciting topic that I know stresses a lot of us out, hair loss. And I'm really honored here today to have Dr. Melissa Piliang, a double board certified dermatologist and dermatopathologist at the Cleveland Clinic, where she serves as chair of dermatology and co-directs the dermatopathology section. Dr. Piliang's interests include hormonal disorders, women's health, and of course, hair loss, which is what we're going to pass the baton over to her today here in a moment. But welcome, Dr. Piliang. It's great to have you here today.
Thank you. My pleasure to be here with you.
So, I think hair loss has really gotten a lot of attention. I kind of tease since the Oscars and that famous slap, alopecia became a word that everyone was sort of using and sort of just haphazardly passing around. And all patients come and say, oh, I've got alopecia. And I don't really think they have a great understanding of what that may truly mean. Do you mind kind of just explaining what alopecia means like as a category and kind of how that's inclusive of other types of hair loss as well?
Sure. Happy to do that. And I think you're right. Hair is hot right now. It's really it's buzzing in social media. It's buzzing in our clinics. I think it's buzzing in our lives. So thank you for having me here to talk about it. So
Of course.
alopecia is the general medical word for hair loss. So it encompasses all types of hair loss. And just saying alopecia doesn't really tell us which kind. It just means that the hair on the scalp has thinned or there may be scalp showing through. We have to add some other words to get to a diagnosis. So the type of alopecia that the slap was about was alopecia areata. That's an autoimmune disease where people lose quarter or dime size patches. Sometimes they lose all their hair. The kind we see most commonly and that we'll focus on today is called androgenetic alopecia. And that's kind of male or female pattern hair loss where it tends to be on the vertex or the top of the scalp.
And that's probably, I think, one thing that stresses people out, as I mentioned, earlier, just hair loss in general. But we see we're getting older. One of the first things we're looking at that part, in the mirror, we see it's widening a little bit, or people just may pull their hair back in a ponytail. I think especially for those that carry long hairstyles, like, gosh, it doesn't feel as full as it used to be. Can you explain why then when, I might, over time develop hair thinning, and then my best friend could be sitting next to me, we're relatively the same age, and she's not developing it over time. Why do some people get thinning as we get older and other people don't?
Yeah, there might even be variability within your family. So you might have a sister who's about your, little older, little younger, maybe older, and you've watched and still has all their hair, and you're noticing that your hair is thinning. There are many factors at play. One is genetics, of course, but then you would think that it would affect your sister also. But we don't get the exact same genes from our parents, and it's all in how the genes of alopecia, of androgenetic alopecia, are really all about how they mix up. It's not one gene, it's how multiple genes interact with each other. And about 15% of men with androgenetic alopecia have no family history. So even if
Oh,
you don't have anybody else in your family, it doesn't
mhm.
mean that you can't still have androgenetic alopecia. Other factors that are at play are things like nutrition or hormonal things. So people who are very overweight can have alterations in hormones that can make them more likely to lose their hair. Sometimes people who are very thin or eat very restrictive diets might have nutritional deficiencies or things that affect their hair over time. And at the bottom of it, we probably all thin at least a little bit as we age. I think of it like the other parts of our body that thin with aging. If you think about our skin, it becomes more thin as we age. The vaginal mucosa becomes more thin as we age. Our bones become more thin as we age. It's part of how our bodies evolve through the aging process. That doesn't mean you have to like it, and it doesn't mean you can't do something about it, but it
Exactly.
is part of that process.
But I think that's really important you highlight that, the genetic component, how variable it can be, within a single family. And you're right. Some people come and say, nobody has it in my family. Why do I have it? And sometimes I tell you, well, it's kind of the cards you're dealt in life. Sometimes we get a bad hand and it's nothing you've done, like you mentioned. And I think for people, it's frustrating, but it's good for them to know that. And you're right. We hate to blame things on age, but unfortunately the hair, it takes a toll on that too, with various degrees, I think, for all of us. So really important to highlight. I think once we kind of, have somebody you suspect maybe have that kind of hair thinning, what do you see on exam? If somebody comes to your office, somebody's worried, hey, I think I may have, age-related hair loss or androgenetic alopecia, how do you evaluate them? What helps you kind of, get to that diagnosis for them?
Yeah, so I like to look really closely at the hair and at the skin of the scalp. Usually in people who have androgenetic alopecia, the thinning is primarily on the top of the scalp, so that's where we're going to look first. Initially, that part gets a little wide. In women, the frontal hairline, that front tends to be preserved, unlike men. But we often see what we call M recession. So these corners tend to go back, or maybe the hairs are just very short or not as many as used to be there. Those are all clues that you're looking at androgenetic alopecia. Other clues are that the hairs can have variable size. So part of the process is that they start to miniaturize or get relatively smaller over time. So we can look at it, use a special light, but sometimes you can just see it with the naked eye, can be really helpful also. The other thing I would say in women, so we think about this as a problem on the top of the head, and in men, we're used to seeing men with androgenetic alopecia. They maintain pretty good density in this band around. Women tend to thin more diffusely rather than just on the top. It's most pronounced on the top, but if you look through their scalp, they're often thin farther down.
And after you do an exam, because I have patients ask this too, like, well, can you, look at my scalp more closely? Is there a lab test or should I have a biopsy? And maybe we should tackle that first. I think sometimes it's hard for patients to accept that we can maybe look and make a clinical diagnosis. So do you feel like there's a role for a biopsy if you suspect female or male pattern baldness? And if so, when do you prefer to do it?
Yeah, so I often make the diagnosis without doing a biopsy, and I'm a dermatopathologist. So I look at slides, I look at a lot of hair, a lot of alopecia biopsy slides. I really love a biopsy to make a diagnosis, but in alopecias, the biopsies can sometimes be misleading. They can sometimes be confusing. And really, when I'm looking at a alopecia biopsy, the first thing I say when I put the slide up is, what does the clinical look like? And so I'm
Mhm.
looking up because they show me the picture of the clinical and we look at it all together as one piece. So that clinical piece is very important. There might be times when a biopsy would be helpful. If there's inflammation on the scalp, so your scalp is pink or red or scaly, if you have a pattern where somebody thinks maybe it's not androgenetic alopecia, maybe it's alopecia areata. Sometimes that can present in a diffuse pattern, and then a biopsy could be helpful. If in Black patients, they can develop a disease called centrifugal cicatricial alopecia. This is a scarring process that tends to happen on the top of the scalp, the same place that androgenetic alopecia happens, and it can mimic the pattern of androgenetic alopecia. So sometimes in those patients, I'll do a biopsy because the biopsy can tell me if there's scar there or not. And then we would treat it slightly differently. And we would have a different discussion about what our prognosis is and what we think is going to happen. So there are instances where a biopsy can be helpful, but often I make the diagnosis without one.
And I think that's really helpful for people to understand, there are patterns of recognition where we can be pretty confident. And if we're not sure something tends to present somewhat atypical or we're suspicious with the inflammation, that maybe a biopsy is helpful. I know a lot of people too come in searching for some sort of internal cause. They think, I'm thinning, it's got to be my thyroid or my nutrition isn't great, which we know can be contributory. When do you sometimes recommend lab work, or do you do that in anyone that comes in with alopecia?
I often do lab work. When patients come to me, they've often seen other dermatologists or many other physicians about this problem, and I want to make sure that we're being complete and that we know that there's nothing internal that's contributing that, because I know if we address those internal issues, the hair will get better. So and I'll review old labs, but if it's been a year since they've had thyroid checked, I'll check thyroid. That's especially true if someone comes in and tells me it's happened quickly. Their shedding a lot, those are two signs that then I would think more closely about thyroid, and especially if they have other things like they've gained weight or lost weight, they feel hot or cold when others are comfortable, they're tired all the time. That can be many of us tired all the time, but those are other clues that I would want to check a thyroid. I often check an iron, the iron studies. So I do an iron and a TIBC and a ferritin and look at the whole picture of those labs. I do this more in women who have not gone through menopause, especially women in their late 30s and 40s who've had babies, who've had a lifetime or decades of having menstrual periods, because that over time we know runs down iron levels. And iron is really important for hair growth. So I look and check to make sure that they have good iron. If someone is 60 and they haven't had a period in 10 years, I think that's a much lower yield test than someone who's 45 and tells me that they bleed for 2 weeks out of the month and bleed clots. So, those are history points that can be helpful. I often check a vitamin D. I live in Cleveland. We don't get enough. It's cloudy. We were just talking about how we've reached
Exactly.
season, and the sun is not high enough in the sky to induce vitamin D production in Cleveland from, about now until late February. So we have a lot of vitamin D deficiency, and vitamin D deficiency many people who come to see me for hair loss don't regularly follow with a primary care doctor. I might be the person who would pick that up. And we know it helps mood, it helps prevent heart disease and some cancers and other things. So I do check vitamin D, and often I find it and I treat it appropriately. There's some data that suggests that vitamin D may not stop shedding or may not be the cause of shedding, but that it's really important for hair regrowth. Is to get that hair to go from the shedding cycle to the growing phase and get regrowing, then vitamin D is very important. So I think I check often. And zinc is another one that I check not infrequently, especially women who exercise, people who eat a vegan or vegetarian diet, people who do things that sweat a lot. Those are all kind of risk factors for zinc deficiency, and worthy of a check at least once, just to make sure that everything is okay. And then in androgenetic alopecia, we know that male type hormones can drive that for some patients. So I ask and look for other signs of hormonal abnormalities, androgen excess. So if they have acne or had bad acne as a young person, if they have trouble getting pregnant, which can be a sign of PCOS, if their body is that they're bigger in the middle and smaller in their arms and legs, I would think about checking it. I ask if they've had ever had cysts on their ovaries, if they have extra facial hair or hair on their breasts or their lower abdomen. Those are all things that make me want to check those other hormones and just be sure, because if we find a hormonal abnormality like elevated DHEAS or testosterone, we might try some different treatment options.
That's great, because I think a lot of people, think that maybe that's the ultimate cause. And I try to explain to them, like you're talking about, if any of those things aren't right, correcting them will only help us. And if they are hormonally driven, definitely correcting those makes a big difference. And I think it's important to, like you highlight for patients, that often sometimes, these labs are normal too. And it's really the process of just kind of the changes that occur over time that we're going to be fighting against. But to be inclusive, I think it is nice to unturn those stones, because if we can find it and treat it, that's fantastic. And outcomes often will be better for those patients too. And sometimes it's nice to find something. I had a patient tell me that you just find something. I think it was hard for her to believe, just looking on exam, supporting it. But she was like, if something was just lower abnormal, it would make me feel better. And I said, sometimes it does, but I said, unfortunately, sometimes it's not there. But checking it, like you mentioned, great idea to make sure it's thorough and unturn those stones and treat accordingly. And I think too, when you get some of the feedback, I even have patients, those labs are normal, especially when you're looking nutritionally. And I think zinc is a good one to highlight that I think often is forgotten in a workup. Now there's a big turn, especially on the market, with using supplements to treat hair loss, and obviously very readily available. You can walk into the drugstore, go online and buy them. So I want to get your thoughts on, what do you think the value of supplements, what do they offer for us, especially for patients that have that age-related thinning?
Yeah, so I think multivitamins are hard to prove whether they help or not, right? Vitamins, because we get vitamins not just from the pill, but from the food we eat and the things we do. So I think most people who eat a healthy diet, they eat lots of fruits and vegetables, probably don't need a multivitamin. But I worry about people who eat restrictive diet, who follow unusual eating plans. So people who are vegans or vegetarians, people who do low carb, people who fast or restrict calories, people who go on juice fast, like those kind of things. I worry about nutritional deficiencies. Even some of my patients who are taking these GLP-1 inhibitors and their appetites have changed significantly, then I think it's really important to fill in those gaps with a multivitamin. And that's how I think of the multivitamin, is it fills in the gaps when we don't eat perfectly. So I do often advise a multivitamin if people eat an irregular diet.
And if their diet's pretty normal, do you think there's value enough to, and again, there's certain ones on the market I know that patients will come in and ask about, like Viviscal or Nutrafol or just regular biotin or the hair and nail gummies they might see on the shelf. Are there any in particular that you feel like there's more data to potentially support, even though as a supplement, I know not as good as we would love, anything there that you feel like there's value and to offer to patients?
Yeah, a lot of people like to take those vitamins, and I get feedback from some patients that, it's unusual for me to feel like, for my patients to tell me, I took that vitamin and it really fixed my hair. And so I usually don't recommend those. If someone wants to take a vitamin, I think just a standard multivitamin is fine. Many of those have high biotin, and I do worry about biotin for our patients. Biotin is something I used to recommend very regularly when we had fewer treatments and less effective treatments. But what we've learned is that biotin interferes with some lab results. So your level in your blood is not accurately reflected in the output from the machine that blood goes through. And it's because the biotin interacts with some of the chemicals that is how the machine determines what the level is. Thyroid is one, for example, where your thyroid may look normal when it's not, or off when it's actually normal. So if you take a supplement with biotin, you should stop it for a few days before you get any blood work. But there's one scenario where it really makes me concerned, and that is in patients who are having a heart attack or have chest pain and might go to the ER with chest pain. And the biotin can interfere with the blood work that we would do in the ER to see if you were having a heart attack or not. And, that's a scenario where you can't stop it for 2 to 3 days ahead. And you may not be able to even tell people that you're taking it at that point. So I no longer recommend it for patients, and I've had many patients stop it, especially those that are kind of in higher risk heart attack age, over 60 men, but women too.
Really, really great to highlight that, because I think there's just a general assumption if it's a supplement, it must be safe. And, there really isn't any danger, to taking these things. And especially for hair loss, it really appeals to people's emotions, as you know. And so patients are desperate to take any and anything that might actually help. So to understand there are some potential consequences or bad things that can happen, I think that's really important that you highlighted that. In the last few minutes that we're going to have here, because I'd love to have you back to do a more detailed conversation on really diving into treatment, because there is a vast array of treatment to treat androgenetic alopecia, or that age-related thinning. Can you give us kind of an overview of the different types of medications that are available, or maybe your generalized approach? And then we'll dive into detail on our next podcast with you.
Yeah, sure. So let's break it down kind of how you would apply the treatment. So I often recommend an anti-dandruff shampoo. There are studies in men in Europe that showed that men who use an anti-dandruff shampoo had better hair density than men who didn't. So I recommend an anti-dandruff shampoo. I think it's good. It's important to clean the scalp. It's antibacterial and anti-inflammatory. There's a number of products on the market. I usually like ones that have zinc pyrithione or ketoconazole as their active ingredient. I think that first topical options of treatment, over-the-counter minoxidil can be quite effective for many patients. I usually recommend for women the 5% once a day, comes as a liquid or foam. Both are equally effective, but many patients really don't like to have to put that on their scalp every day. And although I have had patients who've done it for years, they don't and they think it helps. Even though they think it helps, they really don't like doing it. So probably, I don't know, 6 or 7 years ago, we started using low dose oral minoxidil. And that has been a very nice advance for our patients. My patients, I find, tend to prefer a pill to the topical version. And patients of mine who've used that topical for years and felt like it was helping, switched to the pill and felt like they got even better. So I often will do the pill form. So that's kind of my standard treatment regimen. If that doesn't work, there are other things that we talk about. You could do a medicine called finasteride, either topically or orally. This is a medicine that we have to be careful in women who could become pregnant. So you wouldn't want to become pregnant while you're using it. But for women who are done having children or who are postmenopausal, it's a really good option. And both the topical and the oral version can be helpful. Another option would be like a laser hair comb. These are sold, many companies sell them. Many have been looked at by the FDA and shown to be safe and potentially effective. I tell people to pick the one they like. If you want the cheapest one, you get the one you hold in your hand. If price isn't an issue, then you can get the one that you have to do for the shortest period of time, 90 seconds, or you can get the one that you sits on your head for 20 minutes and you can like work at your computer or watch TV and chill out while it's going. It's whichever one you think you will use. So those are, that's kind of my standard. If patients have androgen excess or I think there's an androgen component, like they have acne or extra hair growth, then I might do spironolactone as well.
Well, great. That gives us kind of a little taste of where we're going to head next, because I really like to dive into treatment more. Because I think a lot of people say, okay, I've got it, thanks for the diagnosis, but what are you going to do about it for me? So we're going to get into that in more detail the next time we have you on. But before our listeners kind of take off, I want to let you know I want you to offer us, where can they find you?
Yeah. So I'm at the Cleveland Clinic. You can go to clevelandclinic.org or search Cleveland Clinic Dermatology and you'll come up with our website. We have lots of information for patients to read about various diagnoses and treatment options.
That's fantastic. Well, I want to thank Dr. Piliang for coming on, talking about, really hot topic, like she mentioned. Hair is hot right now, and we really do want to help patients better treat hair loss. We know how important that is for you. So stay tuned. Next time we have Dr. Piliang on, we're going to dive more into treatment to give you more guidance on what might be the best treatment for your age-related thinning. And thanks again for coming on the podcast, Dr. Piliang.
Oh, my pleasure. Thank you for having me.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermattrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.